I come to you with great humility as I talk on this topic. I am by no means an expert in diversity, equity, and inclusion, but I have been attempting to educate myself further over the past year or so in this topic, which is increasingly relevant. And I think that's, really the bottom line here is that we're all learning. We all have to be humble and recognize that we all have ways in which we can grow and learn in this sphere. So with that, I will jump right into the case, because everyone loves a case. So this is, sorry, I'm just gonna move this out so I can see. So this is a patient that we saw on our consultation liaison service at New York Presbyterian Hospital, which is a tertiary care, large urban academic medical center with a pretty diverse population. This patient was an 82-year-old white cisgender male. When I say cisgender, I mean that his gender identity is aligned with his birth sex, of Jewish faith, with a history of anxiety, depression, chronic interpersonal difficulties, and multiple medical problems. He was admitted to medicine for an exacerbation of chronic obstructive pulmonary disease. Our team was asked to see him to assess anxiety, and the particular treatment team on CL consisted of an attending psychiatrist, who was also a white cisgender Jewish male, a resident physician, who was a Black cisgender female, and a medical student who was an Asian cisgender male. And then there's me, the service chief, white cisgender female Jewish. My slides are not advancing. They were earlier. Oh, there they go. Okay. So in the initial evaluation, I'm not going to go really into too many details about the patient's clinical history, because I'm more going to be talking about kind of what emerged with the racial themes. But essentially, we felt that he was having difficulties adjusting to his illness and the hospital setting and his growing functional decline. Our plan was to follow him supportively. So this is not a dynamic treatment, but the way I teach on the service is dynamically informed, even if we're not doing a structured psychodynamic treatment. So during the first follow-up visit with the resident physician, he laments his functional losses and refers to himself as feeling like a cripple. He says to the resident, "I forgot that you can't say that word anymore. It's like saying the N-word." The resident says that word is offensive and should not be used. The patient says, "I'm not a racist. If you find it offensive, you can leave." The resident does in fact leave, and then she tells her attending she does not feel comfortable continuing to work with this patient. The attending then comes to me for guidance. I don't know why I'm getting that little sound and
if you manually click the arrow at the bottom left with your mouse, and drag that all the way over to the left. You see arrow, yeah.
Oh, I see.
Right arrow.
Okay. All right, I'll do that instead of my keyboard.
Yeah, manually.
Apologies. Okay. So this is how I felt when this attending approached me. What do I do now? So I think it's important, before getting into any of the psychodynamic and supervision material, to make you all aware, if you're not already aware, that a lot of academic medical centers at this point have formal policies on abusive and discriminatory behavior, because the reality is that regardless of what our personal approach is academically, a lot of us are working in institutions that have rules and policies and guidelines that we have to follow. So I just kind of gave you a screenshot. This is not the full policy because it's very long and detailed, but essentially abusive, racist, and discriminatory behavior is not tolerated in the academic medical center in which I work. NYP in particular has a zero harm initiative and a respect credo, which is reinforcing, commitment to a safe and respectful environment for all involved patients and staff. At the same time, the hospital still is committed to providing compassionate, safe, and high quality care, even as these kinds of situations are addressed. So balancing kind of duty to the patient with issues of abuse and discrimination. These are some guidelines from the residency training director at Weill Cornell about what to do when a staff member or a trainee experiences racial or any sort of discrimination or harassment. It says that, no matter what happens, we have to continue to provide treatment to the patient, even if they're not complying with limits. At the same time, however, a staff member has the right to opt out of remaining assigned to the patient. So we have to continue to provide care, but we can switch the provider if there's an issue. That's kind of one of the big points here. You should ask the staff member if they want your assistance in speaking with the patient. And if they're not sure, you should provide support and help them think through it. Offer the staff access to support in the wake of the incident, and offer a debrief. So, I think one of the things about this is that you'll see there's kind of a movement here towards addressing the therapeutic needs, not only of the patient, but also the care provider or the trainee. And this is kind of a movement away from the traditional self-denying, self-sacrificing, objective physician role, and towards a more humanistic approach of thinking about the physician as having a body with, valid subjectivity. This is consistent with recent trends to address physician burnout and wellness. Sorry, I forgot. Did the keyboard thing again. This is an article by Williams and Rohrbach, who is the training director at Yale, about an incident of racial violence on the unit against a trainee, predominantly verbal assault, and sort of how they dealt with this individually, as a unit, as a community. They argue that it's very important to name and address the racism when it occurs, because this is a decisive confrontation with our nation's legacy of structural racism, an acknowledgement that African Americans in particular have been subject to dehumanizing violent language and stereotypes. They argue that assessing the situation as just a typical disruptive or difficult patient may actually result in ineffective communication, and represents kind of avoidance, silence, and complicity, which is deeply embedded in the structure and culture of medical institutions. So they argue that you should set limits with the patient, as well as, in some cases, using a particular script. So an example of a trainee script might be, we do not use language like that in our hospital. Our teams are made up of people from many backgrounds, and since we want to provide the best care for you, you must stop using that language. The idea is that the script would be corrective rather than punitive. So there is kind of a therapeutic function in there. Suggestions in the don't column, they argue that while undoubtedly well-intended, they were generated by faculty who are not affiliated with underrepresented in medicine groups, which can be problematic. For many African Americans, racism is not something that can be depersonalized, but actually is deeply personal and relates closely to personal safety. So attempting to establish a therapeutic alliance under circumstances where there's overt racial harassment, violence, discrimination is actually unrealistic. And that if the patient rebuffs, it could actually be ethically reprehensible to try to negotiate with a patient who continues to use overt racial slurs and blatant racial hostility. And that a passive stance validates white supremacist views, and attempts to negotiate with the patient are problematic in that context. So moving back to the case for a second, what were the next steps? So I did meet with the resident to do a debriefing. This is honestly one of the first times I've done this. And it was a very powerful experience for me. The resident was almost in tears, extremely angry, expressed a ton of rage, and divulged, in fact, multiple experiences during her residency thus far. She's only a PGY2, during which she's had to endure discrimination from patients. I provided support and validation to her. I removed her from the case because that was what she wanted. She felt very strongly that she did not feel comfortable treating this patient anymore. She expressed appreciation, and she went on to perform very well over the rotation. She was a good resident. So what were some of my reactions? Guilt, and specifically white guilt. Helms has a widely cited white identity model, which is foundational in psychology. And this is the idea that guilt is a normative response in white identity development that can actually develop as early as childhood. And notions of inequality give rise to feelings of guilt about unearned advantages. I had some lesser degree of identification as a Jewish woman who has at times experienced anti-Semitism and sexism in the general hospital setting. But this is a bit problematic because this is a false notion of equality. My position as a white Jewish woman is far from the same as her position as a Black woman. I also had educational concerns. Am I depriving her of a learning opportunity to work in a difficult transference? I had mixed feelings about pulling her from the case. And over the course of this talk, I'm going to argue from what I've read and reflected a lot about this case, it was the right thing to do. But at the beginning, I wasn't so sure. The attending physician, again, identified with the resident in some way, felt guilty about his failure to protect her. He also had a conflicting desire to push her out of her comfort zone and, am I doing the right thing? He said, in the whole experience, I struggled with my role, teacher, de facto parent, supervisor, and was relieved when someone else, that's me, debriefed her while I was left with the medical student. He said, my first association was with my own training and working with anti-Semitic patients, feeling some sense of satisfaction, both helping them psychiatrically and challenging their preconceptions of Jews, and being part of a profession with standards that supersede me as an individual. So again, there's that conflict, even in the past 10 years, with kind of what does it mean to be a physician? Do you matter, et cetera. My initial thought was to push her out of her comfort zone, conflicting with some guilt on my end that I hadn't been there to protect her from an abusive patient. In the end, it was clear she was perfectly capable of protecting herself, and I'm glad I bit my tongue. Oops, sorry. So this is an article just to look at kind of how common of a problem is this in terms of medical trainees experiencing discrimination and harassment. This was a meta-analysis of 51 studies demonstrating that an extremely unacceptably high, actually, number, 59.4%, so almost 60% of medical trainees had experienced at least one form of harassment or discrimination during their training. So this is a very common problem. Verbal harassment was the most commonly cited form of harassment. Racial discrimination was 26.3%, so also very high. Consultants, which was upsetting to me as a consultant, were the most commonly cited source of harassment and discrimination, followed by patients or patients' families. So I wanted to talk a little bit about microaggressions. Now, this is a contemporary form of racism. Research has supported the notion that racism has evolved from more overt forms into more ambiguous, subtle, unintentional manifestations in our society that may actually be more damaging, injurious, and problematic to persons of color even than overt racist acts. This occurs in the daily lives of people of color, is often overlooked and under-acknowledged. And why does it matter to us in the dynamic community? Because Black supervisees actually can experience this in cross-racial supervision dyads. So these are unintentional. And yet, clinical training programs often fail to address ethnicity and culture adequately, and supervisors seldom receive any formal training about these issues. So what are some of the barriers? Racial and cultural diversity are not just overlooked in clinical trainings, but often actively avoided because of the types and intensity of emotion that the subject evokes. Acute anxieties can be mobilized when we name institutional racism and identify it. And there's a paradox in psychoanalytic training, which is that insight is integral to understanding and treating our patients, but it actually appears very difficult for trainees to discuss their insights about their own diversity and that of others during their training. So Siklatira and Foster did a study in the UK where they did kind of a structured survey of psychoanalytic trainees around issues of diversity. Psychoanalytic tendencies are to explore internal psychological issues at the expense of external material issues such as ethnicity. They argue that that's kind of one of the barriers. As Jerry said in my abstract, the majority of psychotherapy supervisors are white, and we know that white supervisors address cultural issues in supervision significantly less than their minority ethnic supervisors, peers. Let's see. So thinking about the blind spots in psychoanalysis, Stout, in the article I'm going to be talking about more about Black rage, talks about Freud's theory of the universal mind as detached from the cultural and social context, which allowed him to disavow the pain of his own racial trauma. And this precedent made it difficult for psychoanalytic theory to subsequently recognize, formulate, and integrate the experiences of the oppressed. Leary has written a lot about this, and she, in her paper on racial enactments, powerfully notes the most common racial enactment has been relative silence about racial issues. We have now developing in more contemporary psychoanalytic theory, particularly theories of intersubjectivity that I kind of dove into recently, especially around having this case. I found, papers by Hamer, Leary, Holmes, really particularly valuable in understanding race as a negotiation between and within persons, and this idea that everyone has the potential state in mind to be racist if you are living in a racialized context. And this is something that's created. Black is not just Black, white is not just white. They're powerful performative identities, and it occurs between and within people. So both, inter and intrapersonal. Psychoanalysis has done a good job of articulating the mechanics of projection underlying racial prejudice, but there's been a developmental lag in developing effective clinical theory. So like I was saying, in traditional analytic theory, race is sort of seen as a matter of sociology rather than psychology. Kenneth Hardy, he's not a dynamically oriented therapist per se, he's a family therapist. He's the president of the Eichenberg Academy for Social Justice, professor of family therapy at Drexel, and he provides a lot of diversity and racial sensitivity trainings to hospitals and the HHS system and a lot of educational institutions. And I wanted to switch to talking about shame and rage. Shame is a major stumbling block for the privileged. Rage is a major stumbling block for the subjugated. In this case, it really made me think about rage and the trainees' rage in particular. Ken Hardy developed the tasks of the privileged and tasks of the subjugated. I felt that this was a helpful model. So as a privileged person, it's important to resist false notions of equality, to think about intentions versus consequences. While something may not be intended to cause harm, it's important to acknowledge if it does cause harm. Develop a thick skin, continue to try. Like I said earlier, we're constantly learning. Do not become a framer of others' experiences. Tasks of the subjugated, to overcome learned voicelessness. Exhale negative messages that have become internalized, overcome the addiction to change, educate or protect the privileged, deal with one's own rage and channel it appropriately and do not eradicate it. So now I'm going to talk some more about Beverly Stout's article, which I thought about a lot in relation to this resident. Stout argues that Black rage is actually a necessary adaptation to allow for and validate the traumatic experiences of the oppressed. So it's an adaptive compromise formation for people of color suffering racial degradation and trauma. It can actually be a way of psychic growth for the patient and has an adaptive function of promoting resilience. So in the case of my resident, like I said, I struggled with whether or not I should push her further, and the other attending did too. I think for her, she did not feel safe. She was rageful. I think that it would have been very difficult to form a therapeutic alliance, if at all, with this patient, a working relationship. And I think it allowed her to perform her role as a resident better over the course of the rotation because she felt safe, because she felt protected by her supervisors. She was incredibly relieved when I told her, like she was expecting me, almost as though she was expecting me to say, no, you have to continue to work with the patient. So in conclusion, racial meanings should be addressed in supervision, regardless of trainees' ethnicity. Supervisors should initiate discussions about heritage, guide trainees' discoveries of their values, assumptions, and biases related to racism and culture. It's important to familiarize yourself with institutional guidelines. And psychodynamic theory, particularly theories of intersubjectivity, can provide a good basis for students and trainees to learn about these issues. The one regret I have is that I didn't then kind of, send her to the literature to read more about this, because this could have been a learning opportunity for her to read more about these kinds of situations. So I think, this was essentially the first time this happened to me. If this happens to me again, I would do the same thing, but I would, if the trainee was strongly feeling uncomfortable or unsafe, I would remove them from the case. But I think it could also be an opportunity to, help them dive into the psychodynamic literature on this and learn some more about racism and countertransference and transference with patients. These are my references. These are some great papers that I would recommend on this topic if it's something that interests you. A lot of these articles were written by Black psychoanalysts, which I think tells us a lot.